Welcome to Pharmacology. So now we'll talk about metabolism, which is part of the ADME of the Pharmacokinetics section. So there's two other common names for the metabolism, which is also called biotransformation and also detoxification. So this phase is actually divided into two subphases, which is the first one called phase 1 or first pass, which involves cytochrome P450 enzyme, and also the second part, which is called phase 2, which mainly involves conjugation of the molecule. And for this part of the class, you should also know the factors which can influence the metabolism process or the metabolism rate. Okay, as mentioned, there's phase 1 and phase 2 metabolism. So you can see that in the phase 1, the drugs can be metabolized into specific metabolite. So it can be of different activity, active or inactive. And for phase 2, it involves conjugation. And metabolism is a very important process before elimination because its main aim is to convert the lipophilic molecule into a hydrophilic molecule to enable easier elimination process. Because the main elimination route out of the body is mainly through the urine. So if you make a molecule to be more hydrophilic, more water soluble, it's easier to eliminate the molecule out of the body. Don't forget, the body system actually uses this the metabolism of the drugs would use the exact same process as the normal metabolism of food and so on. So yep, all things will go through the same route. Okay, so the main place where metabolism occurs is in the liver and also a little bit in the plasma, in the lung, and also in the intestine. Okay, so let's look at in general what happens to a drug in the body. So the drug can be administered as a prodrug or as an active drug alone. So it can be metabolized into an active metabolite or inactive metabolite. So the active metabolite can produce a desirable response, meaning why the person actually takes the drug, so the therapeutic response and also the toxic response. So together again they could be inactivated eventually and be kicked out of the body. So there are a few examples of prodrug. So here just a little concept about prodrug is that sometimes we have to design a molecule as a prodrug to enable it to be more lipid soluble. So that's why it can pass through the cell membrane and so on in a better way to allow higher absorption. So when it's absorbed, then when it can be transported along with the plasma into the site which it should act on, like for certain organs and so on, or certain cell types, it can be activated by the enzymes at that particular place to become an active drug. So there are a few examples of the prodrugs. So eventually you learn all of them before you graduate. So famous examples such as the ACE inhibitor family, so it's enalapril, can be metabolized into an enalaprilat, which is the active compound, and such as levodopa into dopamine, bencyclovir to acyclovir. So this is mainly happening in the liver as mentioned for phase 1 metabolism. I like to use the Pac-Man theory. We're still in the same era, right? So Pac-Man is this Wii game and there's this yellow thingy. It's like how the enzyme works to me. In this case, we focus on a specific metabolism enzyme called cytochrome P450. It's a huge group, and all these wee monster-ish looking are like drugs. So it's like they'll metabolize everything, which in the body. Because don't forget, the body will normally they recognize the drugs or food or whatever as in a way sort of like alien to the body. So try to neutralize them and make sure that it's safe for us. Okay, so we've got different chemical reactions. As I say, if you blur throughout all these things, please go and revise your most basic chemistry knowledge and how the reaction works. So the main process involved is the oxidation and also reduction and also hydration. Okay, let's look at a photo. Okay, so now we're going to introduce you a concept about the inhibition and also induction of these enzymes. So you can imagine these are like normal enzymes-ish in the body. So again, as this diagram here, this is how where the enzymes are located in the hepatocytes. So it's mainly in the ER phase, which is the endoplasmic reticulum. So what happens is that like any other enzymes, there's three things. One is the substrate. Substrate is whatever that can be metabolized and being break down by the enzyme. The second part is the inhibitor. So as its name, it just inhibits the effect. And there's a third concept here, which is called inducers. So what happens is that um, when we talk about for inducers, it actually increases the overall metabolic rate or the effect of this particular enzyme. So as you know, like all the other enzymes, it has an optimum level it can work on. So does the particular drug or substance or food to induce the enzyme is that it requires the gene transcription process to increase the overall amount of the enzyme in the liver. So for example, if the person is also taking a drug called phenobarbital, which is an cytochrome P450 inducer, it actually increases the amount of enzymes in the hepatocytes. However, remember this process, it requires the turn off of the internal machinery process in a way, so that you need to produce more of this of the enzyme itself. So you can imagine the amount of time required for the inducing effect to be seen will be longer, right? Because it needs time for this process to occur, and also it requires time for this whole process to be reversed, because you have to slowly reduce and cut down the amount of enzymes to produce. So imagine if you take two drugs, drug A and drug B. So drug A is the substrate for cytochrome P450, and drug B is actually the inducer. So what happens is that if you take both at the same time, drug B will also increase the amount of cytochrome P450 enzymes. So drug A will actually experience more metabolism, right? Because there's more enzymes. So when there's more metabolism, higher metabolic rate, so will cause the degradation of the drug A to be higher, right? It's a faster degradation process. So overall, it causes the plasma concentration of drug A to be higher at a shorter period of time, or the maximum plasma concentration of drug A to be slightly lower, right? Cool. If you're still blur about it, think about it. Oops. So here you've got certain very famous examples that you must know. So examples such as carbamazepine, phenobarbital, and other barbiturates, phenytoin, rifampicin, very famous ones that you must. Okay, the second part, which is the inhibitor part, which is a slightly much simpler concept, because inhibiting, you just need to inhibit the effect, meaning the amount of enzymes are exactly the same, but it's just that the activity is reduced. So it can be due to irreversible covalent interaction and so on and so forth. So again, because the inhibitor effect is slightly quicker, because the molecule just need to bind to the enzyme and inhibit the effect. So you can imagine that the effect takes a shorter time to be seen and is easier to be reversed. As long as the drug or the inhibitor is degraded, the effect is gone. Cool. So if again we use a different analogy, if drug C and D in this case, if C is the substrate for the enzyme and D is an inhibitor for the enzyme, so what will happen is that when you take both at the same time, so when drug D inhibits the effect of the metabolic enzyme, so you can see that drug C, which is a substrate, the metabolism rate will be slower, right? Because it's inhibited. Right, so when it's slower, so the metabolic rate is slower, is the concentration of drug C in the blood will be higher for a longer period of time. Cool. So we can imagine that if you take drugs from different drugs, especially, and some of them might be an inhibitor and inducer, it actually influences the overall therapeutic effect of the whole thing, of the drug regime, right? Because when the drug concentration is higher than it should be, there's higher chances of adverse effect. And if the concentration is lower than it should be, obviously it'll be less effective. Okay, and for inflammation, some inhibitors, they're more unspecific. They can inhibit several isoenzymes. So these are the whole list of the things which are inhibitors. Cool. Let's go on further for certain names, subtypes. So for cytochrome P450 enzyme, the most famous one would be the subtype of 3A4, just because that it oxidizes about 50% of the drugs which are available in the market. So as you mentioned, there's three categories. First one is the substrate, inhibitor, and inducers, right? So again, the importance or how serious in a way of the interaction could be due to the inhibitor or inducers depends on a few factors. So one of the very main factor is that depending on how long the patient or the person has to take that particular inhibitor or inducer drugs. So as you can imagine, if the therapy is a relatively shorter one, for example, if for most of the cases, I mean, like for example, antibiotics, the person is not normally on long-term antibiotics, but for certain drugs, like for example, anti-epileptic drug, the person once it's stabilized on it has to take it for long term. And rifampin and all is another class of antibiotic which is used mostly here, for the treatment of TB. So you can imagine the treatment duration of the person taking the particular drug will be much longer. So again, this will play a greater impact on the overall drug regime that the person is taking. Right. So we talk about some of the mechanisms. So yeah, for the inhibitor for cytochrome P450 so it could be itraconazole, ketoconazole group. So this drugs actually act as a competitive inhibition on the enzymes. However, it's just something to note that not all interaction is not undesirable. Sometimes it can be actually a good thing. So for example, this concept is of inhibitors are exploited for the HIV drugs. As you can see here, okay, these HIV drugs is actually a substrate and also an inhibitor for the cytochrome P450 Excuse me. So when you use these drugs as a combination therapy, which often happens for HIV, we should normally use combination therapy anyway. We can actually use these drugs at a lower concentration to the patient because then with a lower concentration, it reduces the localized gastrointestinal GI side effects. However, due to its inhibitory effect on the metabolizing enzyme, it can actually causes a higher concentration of these drugs in the plasma. Cool. So meaning you can give a lower concentration as you would like to be to reduce the side effects, but it can accumulate and cause a high enough concentration in the plasma, right? So there are a few agents here. As you can see, they are not really drugs. For example, grapefruit juice is becoming more and more popular locally just because there's more people importing it. And also there's another herbal extract here called St. John's wort, which is an inducer, right? So another example of the subtype of cytochrome P450 enzyme is cytochrome P450 2D6, just because it's 30%, it's metabolizing 30% of most of the drugs. As you can see here, the famous few substrates of this particular enzymes are mainly those drugs which act on the brain. For example, this 5-HT reuptake inhibitors, antidepressants, and antipsychotics. So more details, you'll study more in the future. So don't forget, this is cytochrome P450 2D6 for mainly the brain drugs. Okay, there's another few smaller subtypes such as 2C19, 2C9, 2E1, and 1A2. Right, so as you can see here again, sometimes it involves child grilled meat and some normal daily food, and even some tobacco here. Okay, so the following examples would be more details on the chemistry part on how how the reaction works. Remember, it's mainly an oxidation reaction for phase 1, right? However, for the purpose of this class is mainly just to know the names and some of the important points, because more details of it you cover a lot more in MedChem. Right, hopefully these charts will help you in your revision as well. So you can see it's mainly of the oxidative uh, reactions here, as you can see, right? There's also some reduction process, and yep, and here just to take note, some books that categorize hydrolysis as phase 2, but some categorize it as phase 1. And here, so phase 2 metabolism, conjugation is definitely a phase 2. So there's a few very famous processes. So the first one, for example, is called glucuronidation, meaning you actually attach this big molecule called UDP, glucuronic acid, to the drug molecule. So you can see that although the overall size of the molecule is bigger, but you can see it has much more OH, COH, or the hydrophilic group to make it easier for the elimination process. So there's another process called acetylation. Again, involves this acetyl coenzyme A. And there's another one, famous one, which is called glutathione. So again, you attach a big molecule to it. Okay, just some brief overview about the metabolism route. How does it get to the liver? So this is mainly for drugs which are being taken at an oral form. So obviously first it has to go through absorption process in the intestine. Later on it must be transferred to the liver. So the road which is used to transfer is called hepatic portal vein. Hepatic portal vein, very important. So this then allows the transfer of all whatever which is absorbed from the intestine into the liver, which is again like a detox factory. So it has to go through all sorts of metabolism before it actually transports everything into the blood system. So this is like a safeguard entry point before it gets through the whole body. Right, there are also other absorption sites, which are like, for example, nasal, skin, tongue. So all this actually undergoes minimum first pass metabolism compared to the oral form. So this whole process, just to emphasize, is called first pass metabolism. The first passing of it. Okay, so there are several examples of the drugs which undergo super extensive first pass metabolism. For example, some of the very famous ones would be from the nitrate group, like for example GTN and also isosorbide dinitrate. So these drugs, when they undergo very extensive first pass, for example, it's like among the 100% of the dose that you take, probably is just 20% or 10, something like that, percentage left after the metabolic process. So that's why these drugs, they are not very suitable to be given as oral form. Some of the examples here are still given in oral form. However, some of them you have to do something to the Celtic site in the way you pack the drug into a specific formulation so that there's more drugs which can enter the systemic circulation. So these are some of the examples, but also bear in mind that in the case of, for example, statins, which is an hypercholesterol drug, is actually a good thing whereby it undergoes very high first pass metabolism, because it's supposed to act mainly on the liver. So the effect would be sort of concentrate at the liver and stops at the liver. Cool. Okay, so this is like some of the examples of the overall process of a summary of an example of drug for metabolism. Phase 1, phase 2. Again, just to make the overall product, more hydrophilic. So examples again for paracetamol. So these are again some of the examples. But yeah, here just sorry for being blocked up. Okay, so here you can see paracetamol actually forms this glutathione conjugation, right? To be neutralized in a way, but it can also be toxic when there's too much of it. Oops. Okay, so and this is an overall summary for what you should know for the metabolism process. So there are a few factors here which can influence metabolism. So some you should really go through, which are the drugs, which you can be an inhibitor or inducer, right? There are also some other reasons, such as the genetic background of the person. It's coded for a slower enzyme way or fast version. So some people, if they might have liver disease, again, you expect the whole process to be not that efficient, which i.e. becomes a bit slower, and also the age factor. So here's say again, pharmacogenomics, environmental food or drugs, physiological status if they're too young, meaning the system is not fully developed for the metabolic enzymes in the liver. If they're too old, again, the process gets slower. Liver, cardiac, and thyroid diseases. So, for example, for hyperthyroidism, the overall metabolic rate of the person will be much higher. So, this indirectly causes increase in the metabolism of the drugs as well. So a little bit about pharmacogenomics, again, it's about an allele stuff. So just read this through. So for specific examples would be like, for example, poor metabolizers for Caucasians, right? They can be ultra rapid metabolizers. They can also be fast or slow acetylators. Okay, so yep, these are some of the very specific examples. Again, however, they're not really used that much clinically. Hopefully, they'll play a bigger role in the future. Right, so yep, some other examples here. Just to take note for the effect of the alcohol is actually quite interesting because chronic consumption of alcohol actually induces this cytochrome 2E enzyme in general. But if the person is taking a high dose of alcohol as a binge drinking, by just a high dose, one shot, it actually inhibits the enzyme. Okay, that's all for now. Happy revising. Ta!